Hello everyone, it's Dr. Mohib, and in this lecture we'll be going through cardiovascular physiology. Now the topics covered in this lecture are number 1, Frank-Starling law, Frank-Starling curve, cardiac and vascular function curves, and at last we will have memory drills. Now first of all, Frank-Starling law. Now what is Frank-Starling law? Frank-Starling law states that at constant contractility, the force of contraction is proportional to end diastolic length of cardiac muscle fiber. Now, this states that the force of contraction of heart is directly proportional to preload. Now, this means that heart behaves like an elastic fiber. The more you stretch it, the harder it will contract. And this is the Frank-Starling curve. On x-axis we have stroke volume, while on y-axis we have stroke volume, while on x-axis we have ventricular and diastolic volume or preload. And Frank-Starling curve shows the relationship between stroke volume and preload. So if you look at the black curve, this is the normal heart behavior or the relationship between stroke volume and preload at resting condition. So this is, if we suppose this is the stroke volume and this is the end diastolic volume or preload of our heart at resting condition. Now there are shifts in this curve. This is known as left shift and this is known as right shift. Now what does left shift means? Now left shift means that for given end diastolic volume or preload, the heart generates greater stroke volume. So if you look at the left shift or the blue curve, so for given end diastolic volume, heart generates greater stroke volume. So this is the left shift of Frank-Starling curve. And on other hand, we have right shift. So what does right shift means? Right shift means that for given end diastolic volume, heart generates lesser stroke volume or cardiac output. So this is right shift. Now, what are the conditions which shifts the curve to the left or right? So the first thing is contractility. Now the first thing is contractility, and other thing is total peripheral resistance. So if we increase the contractility, the curve shifts to the left, and on the other hand, if we decrease the total peripheral resistance, again the curve shifts to the left. And then for right shift we have vice versa. If we decrease the contractility, the curve shifts to right, and if we increase the total peripheral resistance, the curve shifts to the right. So let's switch to first aid or read the first aid. Now, increase in contractility, it can occur with catecholamines. So any state or condition which increases or activates the sympathetic autonomic nervous system will lead to an increase in catecholamines, and thus we have left shift likewise which occur in exercise. Then we have positive inotropes. Positive inotropes are the agents which increase contractility. For instance, we have dobutamine, which is a sympathomimetic drug which has beta 1 and beta 2 activity with more beta 1 activity than beta 2. Then we have another drug known as milrinone, which is a PDE3 phosphodiesterase 3 inhibitor, which increases the cyclic AMP within the heart, which leads to increased contractility of heart. And we have another drug known as digoxin, which is a sodium potassium ATPase inhibitor, which again leads to increased calcium within the heart, leading to increased contractility. And what are the conditions which leads to decreased TPR? Now, decreased TPR can be achieved by vasodilators as well as in conditions like sepsis or anaphylactic shock or anaphylaxis. Then we have decreased contractility. Now, what are the conditions which leads to decreased contractility or the right word or the right shift of the Frank-Starling curve? So, one condition is loss of functional myocardium, for example, which occurs in MI. In myocardial infarction, we have loss of cardiac myocytes. Then we have drugs, for instance, like beta blockers, which again leads to decreased beta 1 activity which leads to increased contractility. Thus we have decreased contractility, or in other words we have rightward shift of Frank-Starling curve. Then we have calcium channel blockers, specifically the non-dihydropyridine calcium channel blockers like diltiazem and verapamil. These are non-dihydropyridine calcium channel blockers like diltiazem and verapamil. And then we have heart failure. In heart failure we again have decreased contractility. And what are the conditions which leads to increased TPR? So vasoconstrictors leads to increased TPR, which can again shift the curve to the right. And this green curve, this curve which I am marking green, this is the heart, when the heart failure curve, when we give the patient positive inotrope. So in this state we have a little bit of increase in cardiac output or the stroke volume for given end diastolic volume, but still it is less than the normal state. So by giving positive inotropes to the heart failure patient, we can increase the cardiac output or stroke volume than the disease state, but still it is less than the normal condition. Then we have another curve known as vascular function curves. Now vascular function curves, in vascular function curves we have a relationship between venous return on y-axis and right atrial pressure on x-axis. So the curve is somewhat like this. We have a decrease or decline in this curve, in specifically the venous return curve, and the point at which it meets the right atrial pressure is known as mean systemic filling pressure. This is the pressure which is present within the heart after heart stops. So when heart stops, the pressure within right atrium is known as mean systemic filling pressure. We have a question. A question arises: why this curve declines? The reason is that if we increase the right atrial pressure, then we have the gradient for venous return decreases. Blood reaches right atrium due to the gradient or the pressure difference between the pressure within the peripheral veins or venules and the right atrium. So the pressure within right atrium is low while the pressure in the peripheral veins is high. So blood moves from the high pressure areas like peripheral veins into right atrium. The pressure is high over here and pressure is low within right atrium. So blood moves from peripheral veins into right atrium. So if we increase this pressure, then the gradient diminishes and we have a decline in venous return. Initially, we have a vascular or the venous return curve and the Frank-Starling curve. But initially, cardiologists were puzzled or weren't sure which of the following curve depicts the real time cardiac output or the cardiac activity. But when they joined or combined the two curves, they have a point known as cardiac, or the intersection of these two curves is known as operating point of heart, or this gives a real-time depiction between real-time depiction or real-time value of the cardiac output. So the intersection of two curves, the Frank-Starling curve and the vascular or the venous return curve, is the operating point of heart. So the intersection of curves, the operating point of heart. Venous return and cardiac output are equal as circulatory system is a closed system. Now let's switch to curves. We have first, or the A. So if we increase the inotropy, what happens to the curves? So if we increase the inotropy, the curves shift to the left, specifically the cardiac function curve. And on the other hand, if we decrease the inotropy, the curve shifts to the right. So let's review A. Initially, A, we have inotropy. So changes in contractility leads to altered stroke volume, and the altered stroke volume leads to altered cardiac output and venous return and right atrial pressure. So what are the factors, or what are the things which leads to inotropy, the positive inotropy and negative inotropy? So if we look at number one, catecholamines, again, like the factors which activates the sympathetic autonomic nervous system, like exercise. Then we have dobutamine, digoxin, and exercise. All of these factors activate the inotropy, or leads to positive inotropy, or in other words leads to leftward shift of the cardiac function curve. So what does it mean? It means that we have increased cardiac output and venous return for a given right sorry we have increased venous return and cardiac output for given right atrial pressure. This means that a little blood is left within the heart, and or the heart pumps a greater amount of the blood reaching the heart. And on the other hand, the right shift, the condition or the states is the heart failure with reduced ejection fraction, narcotic overdose, and sympathetic inhibition. All of these states leads to decreased inotropy or rightward shift. So if we look at this curve, we have decreased cardiac output and increased right atrial pressure, which means that the blood is pooling within the heart instead of being pumped. Then if you look at this B, or the vascular or the venous return curves, or the venous return. So what changes occurs when we change the venous return, or what changes occurs? So changes in circulatory volume leads to altered right atrial pressure. The altered right atrial pressure leads to altered stroke volume, which leads to changes in cardiac output. So if we look at the curve, again we have right shift and left shift. But the right shift, what are the conditions which leads to right shift? We have increased volume or venous tone. Venous return depends on two things: the volume, circulatory volume, as well as the venous tone. Since vein stores most of the blood of our body, up to 70% of blood of our body is stored within the venous system. So any condition which leads to increased volume, like the transfusion of blood or IV fluid transmission, would lead to increased volume, and the increased venous tone would also shift the venous return curve to the right. So we will have increased, or the shift of right atrial pressure, we will have increased right atrial pressure. And on other hand, if we have decreased volume or venous tone, like if we have a hemorrhage or a blood loss, or if we give the patient drugs or agents which decrease the venous tone, then we will have again decreased curves. So we will have decreased venous return and cardiac output, and decreased right atrial pressure. So number 3, fluid infusion, sympathetic activity, and arteriovenous shunt all leads to increased volume and venous tone. In arteriovenous shunt, we have the bypassage of, or the direct connection between arteries. Normally we have arteries, then we have arteries, then we have arterioles, then we have capillaries, then we have venules, and then we have veins. So blood is pooled within the capillary system, and arterioles function as the regulator. But if we have arteriovenous shunt, the blood bypasses the capillary system, and we have the increased volume of blood within the venous system, or in other words, we have increased venous return. And if you look at the fourth one, or the left shift of venous return curve, which can occur in acute hemorrhage or spinal anesthesia, which leads to decreased tone of the venous system. And at last, the C, we have the total peripheral resistance. So what does total peripheral resistance do? It doesn't change the mean systemic filling pressure. It just shifts the curve, but doesn't change the mean systemic filling pressure. The mean systemic filling pressure is again dependent on venous return, which is dependent on the volume and the venous tone the volume of blood or the fluid within the body, and the venous tone. Since TPR doesn't affect volume and venous tone, so we have a constant mean systemic feeling pressure. It only changes the curve. So what does changing in total peripheral resistance do? If we increase, if first of all, if we increase the total peripheral resistance, it shifts the venous return curve downward as well as the cardiac output curve downward. So this is the new curve. So instead of operating at high cardiac output, it only decreases the cardiac output without changing the right atrial pressure. Why does it happen so? Actually, what is the regulator or the main controller of TPR? It is arterioles. The connection, we have artery, then we have arterioles, then we have capillaries, then we have venules, and at last we have vein. So blood flows from arteries to arterioles, capillaries, venules, and veins. And arterioles are the major regulator of TPR or the blood pressure. So what happens in increasing TPR? Increasing TPR leads to increased afterload or increased activity, or increased, the heart has to do increased work in order to pump blood against this increased afterload. So we will have decreased cardiac output. Another thing, this increased TPR will leads to pump storage of blood or accumulation of blood within the arterial system, the arterioles, instead of the venules. So we will have decreased venous return. So as a result, we will have decreased cardiac output, but the right atrial pressure will be same. Same goes to decreasing TPR. By decreasing TPR, we just shifts the curves both of the cardiac output as well as venous return, but we will have increased cardiac output for given right atrial pressure. So total peripheral resistance, changes in total peripheral leads to altered cardiac output, while the changes in right atrial pressure are unpredictable. So for 5, what are the condition or states leading to increasing or increased total peripheral resistance? So these are vasopressors. And what are the conditions leading to decreased TPR is exercise and arteriovenous shunt. Now, the key thing to remember between these curves is that changes often occur in tandem and may be reinforcing. Like in one condition, these changes do not occur in isolation, rather they occur in combination. So for instance, in exercise, we have increased inotropy as well as decreased TPR to maximize cardiac output. So in exercise, we have increased inotropy as well as decreased TPR. So we will have both of these changes in order to achieve maximum cardiac output. Or compensatory, like for instance in heart failure we have decreased inotropy, which leads to fluid retention to increase preload to maintain cardiac output. This was all about cardiac function curves. One thing which I have missed is that why do we have this phenomena, or why heart behave like this, or the Frank-Starling curve? The reason is that at stretched position, the actin and myosin filament contraction is best achieved. We have actin filaments and we have myosin filament. So the interaction between actin and myosin is best achieved at stretched position. So if we stretch the heart fibers, we have stronger contraction. This is the reason behind Frank-Starling curve or the Frank-Starling law. This was all about Frank-Starling law and cardiac function curves. Now let's go through some of memory drill. Number 1. Which intervention shifts the Frank-Starling curve upward without changing preload? So what changes or what leads to the left shift of cardiac function curve? So is it normal saline, hemorrhage, dobutamine, or spinal anesthesia? Pause the video to think about it, and the correct answer is dobutamine, which is an inotrope and a positive inotrope. Then we have another question. A physiologist increases total peripheral resistance experimentally by infusing a potent arteriolar vasoconstrictor. Which of the following changes will occur on the cardiac and vascular function curve? If we draw the cardiac and vascular function curves, sorry. This is the cardiac and vascular function curve. This is the normal cardiac, vascular and function curve. But if we increase the TPR, we'll have the new curve will act like this. Sorry, the new curve will be like this. So this is the shift of cardiac and vascular function curve by increasing TPR. So what do we have? We have downward shift of cardiac function curve downward. So if you look at the example, upward shift of cardiac function curve, this is wrong, and downward shift of cardiac function curve, this is still acceptable, and downward shift of cardiac function curve, this is acceptable. Unchanged cardiac function curve, this is wrong. So we have to choose between these two. The rotation of venous return curve downward around an unchanged mean systemic filling pressure. So this is the correct answer. We have correct answer as this. This was all about the function curves. Thank you.